Welcome to the Pharm.Net Bridging the Gap Between Science and Practice Train the Trainer session for Cardiology 2. Today's topics include clopidogrel and beta blockers. Today is Thursday, September 23, 2010. This presentation is supported by a grant by the CDC. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of CDC. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Today's agenda includes an overview of the Pharm.Net program, overview of the educational content in this module, future webinar dates, contact information, survey instruments, and a question and answer session during the second hour. All copyrighted content included within this presentation has been granted copyright permission. Therefore, no parts of this presentation can be reproduced in any form without permission of the rights holder. The overall objective of the Pharm.Net program is to increase the awareness about current knowledge of the validity and utility of pharmacogenomic tests and the potential implications of benefits and harms from use of the tests. We have the following educational modules that are available as part of the shared curriculum for faculty members. The webinar dates for these sessions will be provided at the end of this presentation. For today's presentation, we follow the following format, including the gene and/or allele of interest, their functional effects, prevalence rates, the available tests, summary of the most significant clinical data available to date, and this information is organized into literature that affect dosing and drug selection, those that affect efficacy, and those that affect toxicity. And finally, recommendations for genomic testing from reputable agencies or national guidelines are also provided. At this time, we would like to introduce the authors for this module. We have two speakers today. The first speaker is Dr. Larisa or Lori Cavallari. She received her bachelor's in pharmacy and Pharm.D degrees from the University of Georgia. She subsequently completed a pharmacy practice residency at the Veterans Affairs Medical Center in Memphis, Tennessee, and a fellowship in cardiovascular pharmacogenomics at the University of Florida. Dr. Cavallari is presently an associate professor of pharmacy practice at the University of Illinois at Chicago. In her current position, she is actively involved in translational research focusing on genetic contributions to cardiovascular drug response. Our second speaker today is Dr. Jaekyu Shin. He is an assistant professor of clinical pharmacy at the University of California in San Francisco. He earned Doctor of Pharmacy degree from the University of Florida. He completed pharmacy practice residency at the University of Miami-Jackson Memorial Hospital and joined the UCSF after completing a 3-year cardiovascular pharmacogenomics fellowship program at the University of Florida. Dr. Shin's research goal is to promote safe and effective use of drugs by using pharmacogenomic information. His research interest is clinical application of cardiovascular pharmacogenomic tests, including warfarin clopidogrel pharmacogenomic test. So now I would like to give the time to Dr. Cavallari.
Thank you. So during this presentation, Dr. Shin and I will talk about clopidogrel and beta blockers in regard to pharmacogenomic testing and how it can be applied to clinical practice. Another objective is to summarize the evidence-based recommendations for pharmacogenomic testing with these two drug classes. And then finally using patient case scenarios to formulate a plan for pharmacogenomic testing for clopidogrel and beta blockers based on the available evidence. I will begin by discussing clopidogrel pharmacogenomics. I will focus specifically on CYP2C19 and its associations with clopidogrel response and clinical applications. And then Dr. Shin will talk about beta blocker pharmacogenomics. He will be focusing on both the beta-1 and beta-2 adrenergic receptors and their associations with beta blocker response and clinical applications. So I think I skipped a slide there, but this is we'll begin with the Clopidogrel pharmacogenomics section by discussing a patient case. JM is a 55-year-old Caucasian male with hypertension and dyslipidemia. He suffers a non-ST segment elevation MI and undergoes percutaneous coronary intervention or PCI and has 2 drug-eluting stents placed. He weighs 80 kilograms, has no known drug allergies, and genotyping is done for this individual and shows that he has the CYP2C19 *2 genotype. He is started on Clopidogrel at a 300 milligram loading dose, followed by a 75 milligram per day maintenance dose. And so the question that I pose is, based on his genotype, is it appropriate to start Clopidogrel? And if not, then what is appropriate alternative therapy? So we will go through data now to try to address this question. So Clopidogrel is a thienopyridine. Once it's activated, it irreversibly binds to the platelet P2Y12 receptor. As a result, ADP is unable to bind to the receptor, and ADP-mediated activation of platelets and platelet aggregation is prevented. When used in combination with aspirin, Clopidogrel has been shown to reduce morbidity and mortality in patients who have suffered an acute coronary syndrome. This is in patients both managed medically and those who have undergone PCI. Clopidogrel has also been shown that when used in combination with aspirin, it reduces the risk for stent thrombosis after PCI, and it's very widely prescribed. There is evidence of significant interpatient variability, both in the antiplatelet effects of Clopidogrel and also in clinical response to this drug. And just to give you an example, about 25% of patients are considered Clopidogrel non-responders, in that they have evidence of residual ADP-mediated platelet aggregation in vivo or in ex vivo studies. This variability in Clopidogrel response is believed to be largely due to differences in Clopidogrel pharmacokinetics. So Clopidogrel is a prodrug, and once it enters the body, about 85% is hydrolyzed by esterases to inactive metabolites. The remaining 15% undergoes this 2-step bioactivation process, and this ends up producing the active thiol metabolite, which is responsible for inhibiting the receptor and preventing platelet activation. The CYP2C19 enzyme is involved both in the production of the intermediate to oxoclopidogrel metabolite and to the formation of the active thiol metabolite. The production of the active metabolite is impaired in patients who have reduced function CYP2C19 allele. At least 25 different polymorphic variants have been identified for CYP2C19. The STAR1 allele is considered the wild type with normal enzyme activity. And then the STAR2, 3, 4, and 5 alleles are termed loss of function alleles, and they are associated with either reduced or absent enzyme activity. And this occurs as a result of non-synonymous variants in the gene coding region, or in the case of the STAR2 allele, there's a splicing defect which results in complete loss of function. The STAR17 allele results from a polymorphism in the gene's 5' flanking region, and this is associated with an increase in enzyme activity, and it's termed a gain of function allele. The CYP2C19 alleles confer 4 main phenotypes. Individuals with 2 loss of function alleles, and this can be any combination of loss of function alleles. So any combination of the STAR2, STAR3, STAR4, or STAR5 alleles. These patients are termed poor metabolizers. Those with a single loss of function allele, so they have the normal or the wild type STAR1 allele, in addition to one of the loss of function alleles, are intermediate metabolizers. Those without a variant allele, so they have the STAR1 genotype, are extensive metabolizers. and those with one or two of the star 17 alleles, or the gain-of-function alleles, are ultra-rapid metabolizers. There are racial differences in the prevalence of the CYP2C19 phenotypes. As you can see on the slide, Asians have the highest prevalence of both the poor metabolizer and intermediate metabolizer phenotypes. About 60 to 65% of Asians carry a loss-of-function allele. About 2% of Caucasians are poor metabolizers and 25% are intermediate metabolizers. These numbers are slightly higher for African Americans, about 4%, and 30% are poor and intermediate metabolizers, respectively. About 40 to 45% of Caucasians and African Americans have a star 17 allele, so they're ultra-rapid metabolizers. In contrast, less than 5% of Asians have a star 17 allele. So one question that you could pose to your students at this point is, based on the prevalence of these CYP2C19 phenotypes and what we've just gone over with the pharmacokinetics of clopidogrel, which population would be predicted to have the greatest risk or be at greatest risk for reduced clopidogrel response? And the answer here would be Asians. They have a higher prevalence of the poor and intermediate metabolizer phenotypes and the lowest prevalence of the ultra-rapid metabolizer phenotypes. And in combination, what this means is that they may have decreased production of the active thiol metabolite of clopidogrel and therefore be more likely to have decreased response to the drug. Poor metabolizers and intermediate metabolizers require higher doses of clopidogrel or alternative antiplatelet therapy, or they may require higher doses, to achieve sufficient inhibition of their platelet aggregation. And then on the other hand, the ultra-rapid metabolizers may achieve sufficient inhibition of platelet aggregation with lower doses of clopidogrel, and they may actually be at risk for bleeding with standard clopidogrel doses. There have been several cohort studies and genetic sub-studies of several large clinical trials with clopidogrel that have examined the association between CYP2C19 genotype and treatment outcomes with clopidogrel. And generally these findings have been consistent. The exception is one recently published study that I'll talk about shortly. So there was a meta-analysis of 9 of the cohort or genetic sub-studies that was it was presented at the American Heart Association last year. They included about 9,700 patients who had suffered an acute coronary syndrome. And what they found overall is that those with a loss-of-function allele, so poor metabolizers or intermediate metabolizers, had about a 1.6-fold greater risk for a major adverse cardiovascular event during clopidogrel therapy compared to extensive metabolizers. This risk was nearly 2-fold greater in poor metabolizers with 2 loss-of-function alleles and 1.5-fold greater in intermediate metabolizers with a single loss-of-function allele. About 5,800 patients who were included in this meta-analysis had undergone PCI and stent placement, and so they examined the association between CYP2C19 genotype and outcomes in this group. So all of these patients were treated with clopidogrel, and overall what they found is that poor metabolizers and intermediate metabolizers had nearly a 3-fold increased risk for stent thrombosis compared to extensive metabolizers. The risk was about 5-fold higher in poor metabolizers and 2.5-fold higher in intermediate metabolizers. So in contrast to these data I've just presented, there was a more recent paper that was published in the New England Journal of Medicine, and it described results from genetic sub-study of 2 large placebo-controlled trials. And overall, they showed no effect of the CYP2C19 loss-of-function alleles on clopidogrel efficacy. One of the trials that was included in this paper was in patients with acute coronary syndromes, and most of these patients were managed medically. And the other trial was in patients who had atrial fibrillation. And so in each trial they showed that compared to placebo, clopidogrel was as effective at reducing the risk for cardiovascular events A couple things to point out here. One is that only 14% of patients included underwent PCI with stent placement. None of these patients received a drug-eluting stent. And I just got a message that said that someone's lost audio. Can anyone hear me? Hello?
Everyone is muted. Your voice was lost. If you can repeat just from the beginning of this particular slide, maybe, or the middle of it, that may be helpful. Thank you.
Okay, thank you. Okay, so I was discussing the results from the clinical trials with the CYP2C19 genotype, and in the meta-analysis that I presented in the last slide, about 5,800 patients included had undergone PCI and stent thrombosis. And among these patients, if they had the poor, their intermediate metabolizer phenotype, they had a 2.8-fold increased risk for stent thrombosis compared to extensive metabolizers despite receiving clopidogrel. The risk was about 5-fold greater for poor metabolizers and 2.5-fold greater for intermediate metabolizers. And so in contrast to these data, there was another study that was recently published in New England Journal of Medicine and has received a lot of attention. And overall, the investigators for that trial reported that the star 2 and star 3 alleles, the reduced function alleles, did not influence response to clopidogrel. And this particular trial included 2 placebo-controlled studies, or the paper included 2 placebo-controlled studies. One was in patients with acute coronary syndromes, most of whom were managed conservatively, and the other was in patients with atrial fibrillation. And what each trial showed is that compared to placebo, clopidogrel was better at reducing the risk of cardiovascular events, was as effective at reducing the risk for cardiovascular events in those who had an allele as in those who did not have an allele. And it was actually better at reducing events in those with a star 17 allele. And they found no association between any of the genotypes and bleeding risk. So these data, in contrast to previous data, suggest that the efficacy of clopidogrel is not affected by the star 2 and star 3 loss of function alleles. But there were a few things to point out here. One is that only 14% of patients included in this trial underwent PCI with stent placement. And in the U.S., most of our patients now do undergo PCI and stent placement. None of the patients in this most recent study had received a drug-eluting stent, and those patients with drug-eluting stents are at the greatest risk for stent thrombosis and adverse cardiovascular events. And so overall, the study, it didn't include enough people who underwent coronary revascularization to really make any conclusions in this group. And so these findings may not be applicable to patients who undergo PCI. In addition, one of the trials that was included in this paper was conducted in patients with atrial fibrillation, which is not an indication for clopidogrel in this country. And the benefits of clopidogrel in this population are very modest. So that also can be considered when interpreting the results of these studies. I think overall what this suggests is that for patients at low risk, so those who do not undergo PCI with stent placement, that perhaps loss of function alleles will not influence response to clopidogrel, but in those who do undergo PCI with stent placement, that it does. So there was also one study that focused specifically on the star 17 allele. It included over 1,500 patients who underwent PCI with stent placement, and they found that carriers of a star 17 allele had an increased risk for both major and minor bleeding with clopidogrel. The risk was highest in those homozygous for the allele, so with the star 17 genotype. These individuals had nearly a 4-fold increased risk in bleeding compared to non-carriers. And about 5% of people included in this study had the star 17 genotype. And there was no association in this study between the star 17 allele and stent thrombosis. Genetic testing for the CYP2C19 alleles is available. There is the FDA-approved AmpliChip. It genotypes for CYP2C19 as well as for CYP2D6 alleles. And then also a number of diagnostic companies also testing as well. Overall, the loss of function alleles are associated with reduced exposure to the active thiol metabolite, that's clopidogrel, and diminished antiplatelet effects compared to having no loss of function allele. And in contrast, the star 17 allele, or ultra-rapid metabolizer phenotype, is associated with greater inhibition of platelet aggregation with clopidogrel. And in one study, this translated into increased efficacy, and in another, it translated into an increased risk for bleeding. So in March of 2010, the FDA required a boxed warning on the clopidogrel label, and the label was actually updated again last month in August 2010, but the warning regarding the pharmacogenomics was not really changed at this time. And so the label warns that poor metabolizers are at higher risk for cardiovascular events after acute coronary syndrome, or PCI, compared to those with normal CYP2C19 function. It states that genetic testing is available to test for the reduced function alleles, and it advises healthcare professionals to consider alternative strategies or alternative clopidogrel dosing in those who are poor metabolizers. But testing is not mandated. It's not really even recommended. This is for information only, so it's up to the clinician to decide what to do. So another teaching point here, something you could pose to your students, is what they think is missing from this label, what other information they want to know. And in my opinion, there are several things that this label does not address. One is, when should we genotype patients? Should genotyping be done on all candidates for clopidogrel, or should we limit genotyping to just high-risk patients, those who undergo stent placement, particularly if it's a drug-eluting stent, or those with multiple comorbidities associated with thrombosis, such as diabetes? Another question, should platelet aggregation testing be done to verify phenotype? This is not discussed in the label. Another question, how should we alter the clopidogrel dose, and which alternative strategies should be used in poor metabolizers? And then finally, what about intermediate metabolizers? They also appear to be at risk for increased cardiovascular events and stent thrombosis with clopidogrel. Does the same warning apply to these patients? So these are questions that I think that the label does not address. So there are two general approaches for patients who have been genotyped if they test positive for a loss of function allele. One is to start clopidogrel and then see how good it is at inhibiting platelet aggregation. And if the patient has a good response, then you could continue with standard dose clopidogrel. However, if the patient has a poor response, then you could consider an alternative strategy. And this approach might be best for intermediate metabolizers who only have one loss of function allele. And then another approach would be to empirically consider alternative therapy without doing platelet aggregation testing. And this might be the best approach for poor metabolizers who are more likely to have decreased production of the active thiol metabolite with clopidogrel. And so some alternative strategies that could be considered are, first, to increase the dose of clopidogrel. And generally what is being tested in clinical trials is to double the dose. So 150 milligrams per day dose with perhaps a 600 milligram load. Another alternative strategy is to use a different antiplatelet like prasugrel, or perhaps with the ticagrelor once it is available. And then another approach would be to add silastazole to the standard dose clopidogrel and aspirin therapy. So importantly, the clinical effectiveness of these approaches has not yet been established. There are a number of clinical trials that are going on now. Many are only assessing the effects of these alternative strategies on platelet aggregation, but there are some looking at hard clinical endpoints. So we're still awaiting the results of these trials before we have a definite answer of what we should do in patients with loss of function alleles. So one alternative strategy was to substitute prasugrel. And prasugrel is similar to clopidogrel in several respects. It's also a thienopyridine. It also irreversibly inhibits the platelet P2Y12 receptor. And it's also a prodrug that requires biotransformation. However, unlike clopidogrel, the esterase, it hydrolyzes prasugrel to this intermediate metabolite, which then serves as a substrate for bioactivation to the active metabolite. So you essentially don't lose drug during the hydrolysis process. And then also, unlike clopidogrel, it only undergoes one bioactivation step versus two. And importantly, neither the effects on platelet aggregation nor the efficacy of prasugrel appears to be affected by CYP2C19 genotype. And there was actually a trial comparing prasugrel with clopidogrel. It was called the Triton-TIMI 38 trial. And it did show that prasugrel was better at protecting against cardiovascular events in patients with an acute coronary syndrome compared to clopidogrel. However, these benefits of prasugrel occurred at the cost of an increased risk for bleeding. So at this point in your lecture, there is sort of a higher level question you could pose to your students, and that is, based on clopidogrel genetics, why might prasugrel have been more effective than clopidogrel in this trial? And to me, the answer is that this trial had included patients with loss of function alleles as well as those without. But by including patients with loss of function alleles, it may have sort of diluted the efficacy of clopidogrel in the overall clopidogrel-treated group. So another way to say that if the trial was limited to extensive metabolizers, would we still have seen a difference between the drugs? And in fact, there was an analysis of these data that was recently published, and it did show that the outcomes were similar between prasugrel and clopidogrel in extensive metabolizers. Another alternative strategy is to add silastazole. This is a phosphodiesterase 3 inhibitor, has some anti-proliferative effects. And there are some data that triple therapy with clopidogrel, aspirin, and silastazole provides better protection against stent restenosis, as well as decreasing the need for revascularization of the target lesion after a stent is placed, compared to therapy with just clopidogrel and aspirin. However, these benefits occur at a risk of increased bleeding. The triple therapy has not been specifically examined in CYP2C19 for metabolizers or intermediate metabolizers. However, the data are largely from Asian patients, and as we mentioned before, up to 65% of Asians have a loss of function allele. So you could potentially extrapolate from this that triple therapy might be more effective in carriers of a loss of function allele versus dual therapy with clopidogrel and aspirin. So in summary, the CYP2C19 loss of function alleles have been associated with reduced antiplatelet response and worse clinical outcomes with clopidogrel. In contrast, the star 17 allele is associated with increased antiplatelet response, and the star 17 allele may also lead to increased efficacy as well as increased bleeding risk with clopidogrel. The clopidogrel label now contains a boxed warning regarding use of clopidogrel in poor metabolizers, which are patients with 2 loss of function alleles. However, there are no clear-cut guidelines on what to do in poor metabolizers, and there are no recommendations provided for intermediate metabolizers with a single loss of function allele or for ultra-rapid metabolizers who have the star 17 allele. So if we look back at our case, so JM had the CYP2C19 star 2 genotype, which is associated with the poor metabolizer phenotype. We have seen from studies that clopidogrel may be less effective in protecting against adverse cardiovascular events and stent thrombosis in poor metabolizers. So we have several possible treatment options for this patient. We could substitute another antiplatelet drug like prasugrel for clopidogrel. We could try using a higher dose of clopidogrel, like 150 milligrams per day. We could add silastazole to standard dose clopidogrel and aspirin therapy. And I guess another option would be basically to do nothing and continue clopidogrel standard dose and hope for the best. However, I think in this particular patient, he had drug-eluting stents, and he had 2 of them placed. so he's at particularly high risk for stent thrombosis or restenosis, and so I think the best approach would be to use one of these alternative options to provide more antiplatelet effects. But regardless of whatever you choose, you should monitor the patient closely for bleeding. So at this point, I'm going to turn it over to Dr. Shin, who will discuss beta blocker pharmacogenomics.
Thank you, Dr. Cavallari. In this section, I'm going to talk about beta-1 and beta-2 receptor genetic polymorphisms. So we have a case here. CP is a 57-year-old non-Hispanic Caucasian man who was diagnosed as hypertension 3 months ago, and he comes to the clinic for follow-up. His past medical history is significant for hyperlipidemia. Although he has made some changes in his lifestyle, including eating healthier diet and doing regular exercise, his blood pressure is still elevated to 150/87 today. And his heart rate is 86. He is currently on simvastatin 20 milligrams PO daily. He had recently beta-1 adrenergic receptor genotyping done, and he is found to be homozygous for both serine at codon 49 and arginine at codon 389. With this genotype, is CP a good candidate for beta blocker therapy? Just brief background, beta blockers are widely used drugs for various indications. Importantly, 30 to 60% of hypertension patients who are treated with a beta blocker do not achieve blood pressure goal. In addition, it is well known that Caucasians have a better blood pressure response to a beta blocker compared with African Americans. So this data suggests that genetics may play a role in causing difference in response to a beta blocker. So first, beta-1 receptor gene. The gene contains two common non-synonymous polymorphisms, meaning polymorphisms that change an amino acid. They are serine to glycine change at codon 49, and glycine to arginine change at codon 389. The first one, serine to glycine change at codon 49, and these compared with the serine 49 receptors, glycine 49 allele, our glycine 49 receptors are more quickly downregulated after they're exposed to a beta-1 agonist. So people with the serine 49 beta-1 receptors may be considered to have higher beta-1 receptor activity, and they may respond better to a beta blocker than those with glycine 49 beta-1 receptors. Excuse me. Compared with the glycine 389 receptors, arginine 389 receptors have a higher basal beta-1 receptor activity. So because of the higher basal receptor activity, people with the arginine 389 receptors may respond better to a beta blocker compared with people with the glycine 389 receptors. The prevalence of the beta-1 receptors differ by race. The glycine 49 allele is more common in African Americans than in the other races. On the other hand, the arginine 389 allele is more common in Caucasians and Asians than in African Americans. So then what is the effect of the polymorphisms on the blood pressure response? This graph shows that the diastolic blood pressure changed by beta-1 receptor genotype combination. The diastolic blood pressure change was determined after at least 4 weeks of the treatment with a stable or a maximum tolerable dose of metoprolol. There are 4 groups in the study: serine 49 homozygote and arginine 389 homozygote, basically double homozygote, serine glycine heterozygote, but arginine 389 homozygote. serine homozygotes but arginine-glycine heterozygotes, and double heterozygotes. Among these four genotype combinations, the serine and arginine double homozygotes had the greatest blood pressure reduction with metoprolol. Their diastolic blood pressure was reduced by 15% in this study. Importantly, the metoprolol blood concentrations and total daily dose of metoprolol were not different among the genotype combinations. So the difference in the blood pressure response to metoprolol appeared to be caused by the beta-1 adrenergic receptor polymorphisms. Importantly, this finding has been replicated in several prospective studies. So the polymorphisms in the beta-1 adrenergic receptor gene may influence blood pressure response to a beta blocker. Then what is their effect on the clinical outcomes? The INVEST trial compared cardiovascular outcomes in hypertensive patients with coronary artery disease who received atenolol-based or verapamil-based treatment. In a genetic sub-study of the INVEST trial, patients who carried the serine 49 arginine 389 haplotype had an increased risk for death compared with the patients who did not carry the haplotype. And this haplotype consists of the two alleles that may confer higher beta-1 receptor activity, and this may explain why the patients with a haplotype had a higher risk for death in overall. However, among the patients who received atenolol-based treatment, those with a haplotype did not have an increased risk for mortality compared with those without a haplotype. In contrast, among the patients who received verapamil-based treatment, those with a haplotype had an increased risk for death compared with those without a haplotype. Interestingly, there was no difference in diastolic blood pressure among the groups. So this data suggests that beta blocker-based treatment may have a protective role in patients carrying the serine 49 and arginine 389 haplotype compared with the calcium channel blocker-based treatment. However, these findings need to be confirmed in an independent cohort. And beta blockers are used for heart failure, and there are several lines of the evidence that beta-1 receptor polymorphisms may cause variable responses to a beta blocker in heart failure. First, tolerance to a beta blocker. Beta blockers are often not titrated to target doses, in part due to concerns about decompensation during titration. In one study, patients homozygous for the arginine 389 allele required less heart failure medications such as diuretics than glycine 389 carriers during the beta blocker titration period. Second, improvement of ejection fraction. In one study, left ventricular ejection fraction was significantly increased in patients homozygous for the arginine 389 allele compared with that in glycine 389 carriers after metoprolol treatment. Specifically, the arginine 389 homozygotes had an ejection fraction increase from 23% at baseline to 29% at the end of the study. In contrast, the glycine 389 carriers had a change from 22% at baseline to 23% at the end of the study, just only 1% increase. Third, death and hospitalization rate. Usindolol is a non-selective beta blocker. In the BEST trial, it did not differ from placebo in the instance of death and hospitalizations in heart failure patients. However, in a post-hoc analysis, usindolol treatment significantly reduced the instance of death and hospitalizations in patients homozygous for the arginine 389 allele, compared with that in glycine 389 carriers. In contrast, placebo treatment did not result in the difference in the instance between arginine 389 homozygotes and glycine 389 carriers. However, there are also studies that did not show a positive association between the beta-1 receptor polymorphisms and the ejection fraction improvement in heart failure. In addition, the FDA did not grant an approval of Cindolol for the treatment of heart failure based on the beta-1 receptor genetic polymorphisms. So further studies are needed to confirm the influence of beta-1 receptor polymorphisms on beta blocker therapy in heart failure. There is no literature directly related to beta-1 receptor polymorphisms impacting drug toxicity. There is no study that directly looked at whether the polymorphisms impact on drug selection and dosing. However, from the previous studies, beta blockers may be a better choice to reduce blood pressure for Caucasians and Asians than for African Americans because, first, the serine 49 and arginine 389 alleles are associated with a better blood pressure response to beta blocker, and second, they are more common in Caucasians and Asians than in African Americans. Currently, there is no FDA-cleared test for the beta-1 receptor polymorphisms available for clinical use, although we have some data suggesting that beta-1 receptor polymorphisms influence responses to a beta blocker. The level of the evidence strength is not sufficient enough for the FDA and other health professional organizations to recommend the genetic testing for beta-1 receptor polymorphism. Our second gene is beta-2 receptor gene. And beta-2 receptors are also located in heart and vasculature, and some beta blockers can antagonize beta-2 receptors. So the polymorphisms in the beta-2 receptor gene may influence response to a beta blocker. The gene has two non-synonymous polymorphisms that are common in populations. Arginine, they are arginine to glycine change at codon 16 and glutamine to glutamate change at codon 27. This and this one. While some studies suggest that glycine 16 allele has a greater agonist-mediated receptor downregulation, others have reported enhanced agonist-mediated desensitization. So this polymorphism has a bit conflicting data in terms of its functional effect on beta-2 receptor function. On the other hand, the glutamate 27 allele has an impaired agonist-mediated receptor downregulation than the glutamate 27 allele. So individuals with the glutamate 27 allele may have a higher receptor activity, and they may have a better response to a beta blocker. Prevalence of the beta-2 receptor polymorphisms is also different among races. Caucasians have a higher prevalence of both gly16 and glutamate 27 alleles than African Americans and Asians. The clinical relevance of beta-2 receptor polymorphisms. Beta blocker therapy is recommended in post-acute coronary syndrome. In a prospective cohort study, the beta-2 receptor polymorphisms were associated with a difference in mortality rate in post-ACS patients. In this study, 735 patients with ACS were followed for mortality, and mortality was compared by beta-2 receptor genotype. About 600 patients were on a beta blocker in this study. The glutamine homozygote had a 3-year mortality rate of 16%, while glutamate carried 27 carriers had a 6 to 11% of 3-year mortality rate. In addition, arginine 16 homozygote had a significantly higher mortality rate than the glycine 16 carriers. Finally, patients homozygotes for both arginine 16 and glutamine 27 had the highest 3-year mortality rate, which was about 20%. So the beta-2 receptor polymorphisms may be associated with a difference in the mortality rate in post-ACS patients treated with a beta blocker. The underlying mechanism of these findings is not currently clear. Since the glutamine 27 allele is easily downregulated by an agonist, the glutamine 27 homozygotes may have a lower beta-2 receptor activity, and they may not respond to beta blocker. So they may have higher mortality rate in this study. As with most studies in the beta-1 receptor polymorphisms, this study needs to be confirmed in an independent cohort. Okay, toxicity. Like the beta-1 receptor polymorphisms, beta-2 receptor polymorphisms have not been studied for toxicity of beta blocker therapy. In addition, these polymorphisms have not been studied for drug selection and dosing. Currently, there is no test for beta-2 receptor genetic polymorphisms cleared by the FDA, and the FDA and health professional organizations do not recommend for or against beta-2 receptor genetic testing because of the insufficient level of the evidence. Okay, so going back to the case, CP is homozygous for serine 489 and arginine 089. And this genotype combination has been associated with a better blood pressure response to beta blocker. And also, CP does not have a contraindication to a beta blocker therapy. So CP is a good candidate for beta blocker therapy, in my opinion. And the beta blocker receptor gene polymorphisms have not been consistently associated with blood pressure responses to a beta blocker. So in summary, both beta-1 receptor and beta-2 receptor polymorphisms may influence efficacy of a beta blocker in certain indications, but their roles in toxicity and dosing selection of beta blocker is currently unclear. Currently, there is no FDA-cleared beta blocker pharmacogenomic testing, which looks at the beta-1 and beta-2 receptor polymorphisms. However, some commercial clinical laboratories offer beta blocker pharmacogenomic testing, and this testing is mostly CYP2D6 genotyping, not beta-1, beta-2 receptor genotyping. Since the CYP2D6 metabolizes several beta blockers such as metoprolol, the CYP2D6 polymorphisms may influence pharmacokinetics of beta blocker. However, it is currently controversial whether they are associated with variable clinical responses to a beta blocker. So their clinical validity and utility have not been clearly established. And that's all my talk, and thank you for your time, and I will hand it over to Dr. Kuo.
Thank you, Dr. Cavallari and Dr. Shin. We also want to thank several reviewers here at UCSD, and we have a whole team of consultants and project coordinator reviewers, as well as authors and speakers today. In the next couple of slides, I'm going to flash through these references. You can get the handout information once you have registered and once you have completed the training and ready to launch your program at your school. Before we open up to the question and answer session, I just want to quickly go through some of the logistics about our program and some of the upcoming webinar dates. If you have general questions, we welcome you to contact us at pharmacogenomics@ucsd.edu. Dr. Kelly Lee is our Director for PharmGenet Training for Health Professional Schools. If you have specific questions about how to implement this program at your school, please contact her. I am Grace Kuo. I'm the Principal Investigator and Program Director. If you have comments or additional suggestions for topics, or maybe perhaps you would like to help us develop additional modules, please contact me. We also want to acknowledge CDC for giving us funding to make this program possible and available. Upcoming webinar dates include the following. The next one is economic issues. As to all the ones that are completed, if you have signed up and completed the training, you will have access to the PowerPoint handout, questions and answers. The following ones include Psychiatry Module 1 in Depression, which is also scheduled for later in October, and Asthma is tentatively scheduled towards the end of October. Since this program is part of a study, we have survey tools that are available to those of you who will be implementing the program at your school, whether you decide to use partial or the full programs. All the survey materials, including the ones for participants of the series of webinars, will be sent to you at the end of October after the last scheduled webinar for this year. So now I would like to mute the audience and open up the question and answer session. Please submit your questions either by talking directly to the phone, or you can write through the chat feature on the website. We anticipate these questions.
The conference has been unmuted.
Now the floor is open to the audience. I think our speakers have done a wonderful job. They have clearly described and explained the pharmacogenomics pertaining to our topics discussed today. If you have any questions, please ask over the phone, or you can type it in through the chat feature. If you have additional questions that you think of in the future, please also feel free to contact us. I'm going to wait for another minute or two before we end the session.
This is Ron Reed from UBC. I was just wondering, this is sort of a general question to both presenters. What's the point of presenting beta blockers in a pharmacogenomics course when they're really of no value, or at least appear to be of no value? Can you give me a general consensus here? We should be trying to encourage the use of pharmacogenomics rather than giving detractors an excuse?
Well, at this time, it's not quite clear whether it is clinically useful, but it's been extensively being studied in by studies supported by NIH. So hopefully, in the near future, we will use these discoveries for the better care of a patient. At this time point, it's not quite clear whether we can use this information for patient care.
Do you think this lack of clarity is due to poor clinical trials that are analyzing these factors?
Well, there are many conflicting data, and many actually studies, negative studies, about particularly the blood pressure response to beta blocker in terms of adrenergic receptor, beta-1 adrenergic receptor polymorphisms, are actually coming from the retrospective studies. So there are some design issues in terms of why the studies are conflicting. And also, most studies are cohort rather than randomized trials. So also there are many biases that may have been introduced to the studies. So there are some design issues, and the investigators now realize those design issues and straighten up those things, and to make a better design to clearly associate the genetic influence with drug response to beta blocker. So I think we have to wait.
Yeah, good point. Thank you.
All right. If there are no additional questions, we would like to thank our attendees, all of you, and Dr. Cavallari and Dr. Shin for their presentation. Again, if you have questions in the future, please feel free to contact us at pharmacogenomics@ucsd.edu or visit our website at pharmacogenomics.ucsd.edu. At this time, we would like to end the recording session.
Thank you.
Thank you. Please stand by.